To all my colleagues, yet again, it's a Thursday, and I would like to welcome you to the Clinix Health Group webinar presentations that we have been really seeing remarkable speakers joining us every Thursday. And the topics we see are wide-ranging from the academic side of the medical studies, as well as looking at it from the financial point of view, looking at legal ramifications for our practice, and looking at other providers such as the South African National Blood Services that joined us not too long ago. So we see quite a wide variety and a range of specialists and of our colleagues that are joining us and putting their names forward and putting their hands up to do these presentations. One of our colleagues tonight is Dr. Mugwena. Dr. Mugwena is an orthopedic surgeon who will be joining us and doing a presentation. And I will share a little bit more about Dr. Mugwena, who is sitting in his car at the moment because he's so committed in his scrubs. And he's joining us this evening, and he's has a well-prepared presentation that I'm sure you're going to find enthralling, fascinating, and really insightful. So once again, thank you very much for joining us. Just a number of housekeeping rules. During the course of the presentation that Dr. Mugwena will be leading, I'm going to ask the Tolakele to mute and also to make sure that nobody is able to put their cameras on. However, during the course of his presentation, if you have any questions, please feel free to put in the chat group, and we will go through those questions and we'll pose them to Dr. Mugwena and towards the end of the presentation. So please don't be anxious to share your comments with us or anything that you wish to ask. And towards the end of the question and answer session, please feel free to put your hands up as well. I know some of you are bold and brave. You'll put your hand up. We'll unmute you, and you can ask the question directly by way of audio to Dr. Mugwena, who's quite eager to share. And I'm sure you'll answer all the very difficult questions that you have from this evening. So I hope that everybody that is joining us this evening was able to click on the link, the invite that came, and registered on the platform. So you put your name, surname. I believe you would have said where you are from, as well as your practice number, whichever that is, from the various disciplines. And then you would have received an email with a link. You clicked on the link, which then brought you to this presentation. The reason for the registration, again, I know many of our colleagues are well familiar with this, but it's important because we've got new attendees every week. And so the reason for registering is so that you're able to get your points, your CPD points that we are able to get directly from the HPCSA. And then for the nurses, you will receive your certificates as long as you've registered with your link. If a colleague shared it with you, please share your practice number with us so that we can also register you manually to make sure that you do receive your points. And then just towards the end of the presentation, as I said, if there are any questions or anything that you wish to comment on towards for CHG or towards Dr. Mugwena, please feel free to share those with us. Tonight's discussion is rather fascinating, and especially for the sports enthusiasts, and it's for those that, well, Dr. Mugwena, the Comrades Marathon happened last week Sunday, and there are people that are in significant amount of pain and that are quite looking for some solutions. And I know that when you and I first met, you were telling me that you are actually super specializing, especially around the area of pelvic injuries, especially pelvic fractures, which take you significant amounts of time trying to repair all of those injuries, especially those with severe motor vehicle accidents. So thank you so much, Dr. Mugwena, for joining us this evening. So to my colleagues, a little bit more about Dr. Mugwena. He's very, very humble. I can share that with you. And I can let you know that what he shared with us in terms of his bio is nothing compared to the man, and you'll get to hear from him shortly. Dr. Mugwena is a qualified orthopedic surgeon, and he's got advanced training in pelvis trauma surgery. As I mentioned to you, he's one of those that are elite in terms of repairing and assisting patients that have severe trauma when it comes to pelvic fractures. And he holds a MBA-CHB from the University of Medunsa. And then he also did his orthopedic, and then he did his MMed. He did pelvis fellowship at Wits University, and then also in Denver Health Institute in Colorado in the US. He's interested in pelvis and acetabulum trauma, including acute, chronic, and neglected fractures. This evening, however, you can see that he has got an interesting topic, and it is quite a necessary one, especially for those who are running, those that are athletic, and then just other reasons that you may be developing this condition. So Dr. Mugwena, as I said to all my colleagues right now, earlier on, he is sitting in the cold in his car. He's still at work, and so he's sitting with his scrubs on. Dr. Mugwena, you didn't even have a theater gown on, so thank you so much. I hope you don't catch a cold. We're really looking forward to your presentation this evening, and I know you will put your video on towards the end of the presentation. So we really look forward to you, and thank you once again for joining us this evening. I'm gonna pass the screen and the spotlight over to you right now. Thanks, Dr. Mugwena.
Thanks, everyone. I hope I'm well audible.
You are. Thank you.
Oh, okay. And my talk today is gonna be in Achilles tendinopathy and Hagland lesion. So this is one of the most common conditions that we get to see in our elderly patients mostly. So this is due to chronic this is a chronic overuse tendon disease as a result of repetitive endurance runners with a 1-year prevalence of around 11%. 30% of these are sedentary patients who usually present with this condition. This condition can be correlated with seronegative arthropathies and is most likely to occur in a middle-aged patient. The etiology is unclear, but there are many proposed theories on how this condition can happen. So some of the text, like the overlapped into the other slides. Please forgive me on that part. So some of the discussed theories is is that it can be due to neurological problem, especially in the patient with peripheral neuropathy that present with reduced sensation in the feet, so they can get that irritation at the back of the leg, and it can result in Achilles tendinopathy and the Hagland lesion. And then it was also attributed to angiogenic changes, which is due to neovascularization. And it can also due to impingement, especially in patients who wear tight shoes. So the other theory that was discussed is the iceberg theory, which still currently is not yet well understood. So the cause of pain in this patient is usually due to neovascularization around the heel region, also with a new nerve ingrowth. Which usually is going to initiate that inflammatory changes around the region. So this inflammation is usually common in early stages of the tendinopathy disease, but the use of anti-inflammatories, it's usually not well advocated, as by the time the patient present is usually in the advanced stages of the Achilles tendinopathy or the Hagland lesion. So the predisposing factors for this condition, we have intrinsic and the extrinsic factors. So the intrinsic factors, the commonest one is the advanced age and the genetic predisposition. This condition is also more common in a female gender, because they are the ones who usually tend to wear shoes which are a bit tight, or which tend to irritate around that heel region. So the endocrine conditions that are usually common with this condition is usually a hyperthyroidism. But it is also common in patients who present with a lower limb malalignment or a limb length discrepancy. So also in patients with chronic instability because of irritation at the back of the heel, they usually also present with this condition, and also the neuromuscular conditions that can result in muscular imbalances in the lower limb. So the extrinsic factors that predispose the patient is usually the medication. The most common one is is the steroids, either local or the systemic steroids. Even fluoroquinolones, they've been discussed as some of the causes of this condition. So the environmental factors is more attributed in people who spend much of their time mobilizing in uneven or hard surfaces. So most of them, they also present with this condition, and also weekend warriors. So the weekend warriors is those people who usually don't train, but out of the blue, they just decide to sprint for a very long distance or duration. So they can also present with this condition, and also improper footwear, as we discussed earlier, in the form of tight shoes. It can also predispose to this condition. So types of Achilles tendinopathy, it can be proximal, which is the least common, and the mid portion tendinopathy is the most common, which contribute more than 50% of all tendinopathies that the patient can present with, and then is followed by the insertional tendinopathy, which the one is the one which occurs at the junction of the Achilles tendon and the calcaneus. So mid portion tendinopathy. In this one, the patient usually present with pain, which is located between 2 to 6 centimeter proximal to the insertion of the Achilles tendon. Usually, they're gonna present with a signs of necrosis at the back of the heel, or even a calcification inside that tendon. Usually they can present in one of the following three stages, which it can be reactive tendinopathy. So in this part, that is the part where patients usually they wanna feel most pain, but they're gonna take analgesia and delay their presentation to the doctor. The second stage is tendon despair. So here the tendon has become inflamed, and then in the third stage is the degenerative stage, where in this case, because of reduced blood, so that tendon it become calcified, and it get predisposed to rupture. So, but you must also keep in mind that up to 1/3 of patients, they can present being asymptomatic. So detailed history is the one that can guide us towards the diagnosis of Achilles tendinopathy. So Chan classified this condition initially it was classified as intramuscular, which was above the end of the Achilles tendon. It was a free tendon and also a calcaneal. So the free tendon was also divided into three, which was a proximal, mid, and distal, with a distance of around 2 centimeters each from the insertion. So then later on, Klein and Baxter, they modified the classification and divided it into insertional and non-insertional, which is what we are currently using even today, with the insertional being at the distal 2 centimeter and non-insertional being 2 to 8 centimeter from the insertion distally. So proximal tendinopathy, this is the one that currently it is being phased out, this phenomenon. But what will happen is that the presenting pain on the patients when they come is more is above the 8 centimeter area that is usually common with Achilles tendinopathy, and this is the least common type of Achilles tendinopathy, and also it responds well to non-operative treatment, meaning that treatment like NSAIDs, they are the better treatment for this patient in comparison to the other forms of tendinopathy. But treatment is almost similar to mid-portion tendinopathy, which we're going to discuss in the next slides. So mid-portion tendinopathy. So in the mid-portion tendinopathy, the pain is between 2 to 6 centimeter from the insertion of the Achilles tendon distally. So this one can usually be asymptomatic, but once pain starts, it usually progresses even faster. But pain get relieved by offloading that part of the leg. So non-surgical treatment of the proximal and the mid-portion tendinopathy. So treatment mostly in this patient is focused more on reversing the predisposing factors. Because as you mentioned earlier, these are the patients that usually respond well to non-operative treatment. So the success rate of non-operative treatment is up to 75%. So it's more common in athletes. So the early phases of treatment is gonna be to reassure the patient and also allow the patient to rest, because as mentioned earlier that this is okay. When the patient usually present with this condition, is after the first stage of inflammation. So by the time they're gonna be presenting with Achilles tendinopathy, the NSAIDs they won't work anymore, because there is no more inflammation in that tendon. So NSAIDs are not usually advocated, but if the patient think they are beneficial, it is allowed to give them NSAIDs also. So paracetamol, tramal are one of the most advocated treatments. Yes, as mentioned also, we must look for the intrinsic and the extrinsic factors, and also correct the ones that we can correct. So in the management of this patient, it is best to also involve the physiotherapy and the orthotics. So the most used training protocol is based on eccentric heel drop on the affected leg. So what usually happen? Okay, unfortunately, I forgot to upload the picture. So what usually happen is that the physiotherapist they let the patient to stand on the edge of the steps and tell the patient to elevate up and down until around 15 times or until the pain start, and then after that you let the patient rest, and then they can do around 2 to 3 cycles at that time, and then they're allowed to do that up to 15 times in a day. So another form of non-operative treatment is the use of shockwave therapy, which is in the form of sauna, where they try to break down those calcifications inside the tendon. So another modality which is being used is the night splints, which you're gonna be putting the patient's leg in more plantar flexion, so that you can offload the tension in the tendon also. And they are currently also studying the benefit of low dose heparin injections, which currently there is no level 1 study which has approved this. So corticosteroids, either locally or systemic, they are not advocated because they usually predispose the patients to tendon rupture. So if you are giving the patient corticosteroids injections locally, they must not get more than 3 doses in 12 months. So another modality is a platelet-rich plasma, which also is still under study, and in patients with platelet-rich plasma and the patient where the placebo was used, platelet-rich plasma, it was found to be beneficial in around 40% of patients, but still we don't have a level 1 study to advocate for the use of platelet-rich plasma. So after trying all these modalities, if after 6 to 12 months and the patient is still having those symptoms, or they've just improved slightly, then these are the patients that it is advocated to go for surgical treatment. The same slide. So in surgical treatment, the most common one which is being used is the open procedure, which we cut the tendon longitudinally and remove the calcification inside that tendon. But in other centers, they are even doing this percutaneous, which I'm not even familiar with it. So Achilles insertional tendinopathy. This is when the tendinopathy is happening at the junction of the Achilles tendon and the calcaneus. This is because of the 90-degree turn of the tendon prior to the insertion in the calcaneus. So this is one of the most blamed factor in patients who present with insertional tendinopathy. So these patients they usually present with a bone spur at the back of the Achilles tendon. So there are a few factors which are attributed to be the predisposing factors of Achilles insertional tendinopathy. One of them is muscle fatigue, especially in those weekend warriors, and also the patients who may be having contractures in the gastrocnemius muscle, and it can also be due to the imbalance of the muscles, the plantar flexors and the dorsiflexors. So, on examination of this patient with insertional tendinopathy, there is usually swelling and possible calcification at the back of the heel or at the insertional site. And unfortunately, the picture didn't appear here also. So the pain can be worse with passive dorsiflexion, and a limited dorsiflexion can be found. So meaning that in this patient, because of that 90-degree turn of the tendon prior to the insertion in the Achilles tendon, when you try to plantar to plantar flex even more, that is the time where the tension around that tendon is increased and the patient present with pain. So some of these patients will also present with a reddish color around that Achilles tendon, which is referred as the Hagland deformity or Hagland lesion. So X-ray, MRI, and sonar is not usually necessary in this patient, but to rule out other conditions, yes, they can be done. But this condition is usually diagnosed from the history and examination of the patient. So, so unfortunately, I don't have a pointer from my side, but from what we can see in this picture is that this X-ray is showing a bone spur at the back of the heel there, which is where that Achilles tendon is attaching. So once you see a patient who's presenting with a pain in that region, that's going to be insertional tendinopathy until proven otherwise. So on non-surgical treatment, most of the time we start with analgesia, but most of these patients respond poorly to analgesia in comparison to the patient with non-insertional tendinopathy, who they respond better to analgesia. So what is usually done, as we discussed, these are the patients that we're going to be managing with physiotherapy and also orthotics. They're going to give a splint in order to relieve pressure in that region, and also ice around the heel has been proven to be beneficial as it numbs the nerves around that region. So another thing which you're gonna do, you're gonna assess the patient's shoes and check if it's not possibly irritating at the back of the heel also. So another thing is the use of high heel shoes, which can also worsen this condition at the back. Under surgical treatment, these are the patients who, even within 3 weeks from the time of presentation, you are allowed to go and treat them surgically, because it has been proven that non-surgical treatment in this patient is poorer comparing to the surgical intervention. So in surgical intervention, what you do, you start with the skin incision, which it can either be medial, which is the most preferred. It can also be lateral, or it can be directly posterior. And then after that, you're gonna release the paratendon, and then you're gonna resect that calcaneal spur. And then after resecting it, you're gonna attach that Achilles tendon back into the calcaneus, either with anchor sutures if more than 50% of the Achilles tendon was detached. But if it was less than 50%, you are allowed to leave it like that without repairing it. So this is usually on the left side, like that is the spread that we're talking about. And then on the right side is showing the patient post-resection with the anchor sutures in situ. Thank you. This is the last slide.
Hi, Dr. Mugwena. I think I was expecting you to continue on with the presentation. So because we're all gripped now, especially when you started to look at the various interventions that are going on there. I see your colleagues are also excited. You can see all the acknowledgements and appreciation for the presentation that you put forward this evening. I really got to tell our colleagues that joined a little bit later. Dr. Mugwena is sitting in his car. He's supposed to be at home, but he's in theater at the moment. So he stepped out of that and he's sitting in his car with his scrubs on. And he was so committed to joining us this evening that he made sure that come rain or come shine, he's going to be joining us this evening. So thank you so very much, Dr. Mugwena, for the evening and getting everything ready. So you can see everybody saying thank you. And we most certainly appreciate the time and the effort that you put in to these slides and making sure that everything is as informative as it is. Dr. Mugwena, we know we're going to get into some questions and answers in a moment. But just before we do, I just want to say thank you so much for this community, for us getting together and meeting every Thursday and spending time and learning and studying and sharing ideas and information on various topics. And this year has been quite an exciting time. I know you all know we started with the Minister of Health talking about the NHI and where we are. And then we see from a legal perspective, we've had people from the HPCSA come and join us. And there are many other clinical disciplines that are going to be joining us going forward. Just so you know, next week we'll be joined by Dr. Mate, who will be talking to us about bariatric surgery. I'm sure it's going to be an interesting topic, and Dr. Now made it quite famous out there in the States. So we will be having quite a series of really enthralling and engaging conversations and presentations during the course of the remainder of the year. So thank you so much for all of you that are volunteering, including Dr. Mugwena. Dr. Mugwena, for those of you that don't know, he's really a humble person and he's really an amazing gentleman. Before the doctor, before anything else, I remember that I had some trouble with a patient. It was a police officer that had been driven over by a driver that didn't want to stop at a traffic stop. And Dr. Mugwena came out in the middle of night. It was 2 o'clock in the morning and he operated on the patient. Dr. Mugwena specializes in pelvic surgeries, especially severe fractures, patients that have been in either massive falls or motor vehicle accidents. And Dr. Mugwena came out very much a gentleman. And thank you so much for that, Dr. Mugwena. Again, shows your commitment to patients and your love for fellow humanity. So thank you for that. Before we get into the questions also, I just wanted to also acknowledge our colleagues. There are many of you that come on and like Xoliswa, Machine, Amanda, Comley, many times I see people coming on there and saying thank you so very much and good evening to the colleagues. So we just wanted to acknowledge those of you that come on there. I saw Fuad Jetam during the presentation, just acknowledging and thanking you so much. And Avantha Pillay, Xoliswa, I'm seeing all the messages that are coming through and the good evenings. just wanted to say to our colleagues, we do acknowledge you and we encourage that you continue to know that we are there because we are ultimately a community at the moment. Thank you so much, Peggy, for that note. Dr. Mugwena, going into the questions. I hope it's not a contentious one, but you mentioned the etiology around gender. So, and then you talked about high heel shoes, and then you also talked about ladies. Do you want to maybe just go a little bit more into that so that we can give advice to our colleagues? I'm not saying that there are not gentlemen walking around with high heel shoes, but if you want to give some context around that again, please, just to assist so we are cautious about our behavior.
So, so main problem is that anything that can irritate that back of the heel, it can result in Achilles tendinopathy, such as, for example, if we can wear those soccer boots without wearing socks, also, it can result
Okay.
in the irritation at the back. Those shoes, taffies that we were wearing at primary and high school is usually very hard in that region. So also without wearing socks, it can result in this condition. But young people, fortunately, they can remodel easy than adults. So as like it's most commonly in our environment is that most people that wear high heels,
Mhm.
okay, can I say females that wear high heels, like they don't usually put on socks, so there's usually that irritation at the back, in the heel region. That is why most of the time they're gonna present with this condition. It's not only being blamed in females, but anything that can result in that irritation at the back, it can predispose the patient to Achilles tendinopathy.
Okay. Sure, that is interesting. So you're saying the ladies they must wear high heels, but they must wear socks when they do that to reduce the
Yeah,
friction
but
and the
as
irritation.
guys, we won't approve that. Unfortunately, yes.
All right, thanks so much, Dr. Mugwena. I've got Madumetsa Matato, who's a physio, and just saying that he would add that from an eccentric protocol as a physio, they also do transverse frictions, and then they do the ultrasound, as you said, for the midpoint TA to try and break down the fibrosis. So, and just saying thank you. Do you want to make a comment on that?
Actually, yeah, on the physio part, truly, yeah, I'm not well informed, but thanks for the input.
Excellent, yeah. And Dr. Mugwena, I know that you're often referring to the physios, and you are also quite focused on a multidisciplinary team approach.
Yes.
So I
Yeah.
think that is important. And as you were speaking, you were constantly emphasizing that we do not just focusing on it from a surgical approach, but the non-surgical elements and benefits in managing patients, and then also making use of your colleagues in like the physiotherapies, and OTs and so on. And then you talked about the use of corticosteroid injections. So many times patients will come and actually request for intra-articular injections, and doctors tend to give those quite readily. And then they'll tell you, for instance, in the area that you mentioned, there's significant amount of pain. You maybe just want to emphasize that you talked about less than 3 of those injections in a 12-month period, and what actually happens once you are injecting into those spaces. What are you finding as complications?
So what happens is that corticosteroids, like they cause degeneration of almost each and every tendon, even in the knee, in the shoulder, in the Achilles tendon also, or in the heel. So what usually happens is that you don't give body that time to regenerate again from that effects of the corticosteroid. So what usually happens is that it causes those tissues to die, if I can put it like that. Even nerve endings in that region, they're gonna die also. So even those tendons which are getting exposed to that high dose steroid,
Mm.
they're also gonna end up failing, and out of the blue, they're gonna rupture. Most of them, they're gonna report that like they were just doing a normal activity when the tendon just ruptures. So most people, they advocate for two injections maximum in a year, or even two in a lifetime. So if the patient fail those two, then you can go for surgical intervention. So, and another thing is that a patient that respond well to corticosteroid injection, they gonna do good also with a surgical intervention.
Yeah, that is quite interesting. Yvonne Clegg, thank you so much. We see your notes, Ngaya Marundure. We do appreciate your notes and acknowledgement. Then we got a comment here from Ephraim Modengwane, saying, "Thank you, Doctor, for an informative presentation." Ephraim is a podiatrist and says there's a lot of presentation with the ultra marathon runners with patients that are presenting with these kind of injuries. And I am going to just venture into what you were saying. You were talking about these weekend warriors. Many times people want to only run, as you said, on a weekend because they are getting points for their various schemes. And so they do these park run, and that's the only time that they're doing these exercises. So you want to talk about these weekend warriors as opposed to just doing it regularly and consistently during the course of the week and the dangers of that. Thanks, Dr. Mugwena.
Okay, so what will happen is that our body, it get used to the common stresses that we put through it. So if my body is used to me only walking 1,000, 10,000 steps in a day, my body changes will be there to accommodate that. If out of the blue I just start running 20 kilometers, let's just say two times in a month, most of the time that those tissues, like, they are not used to that much stress.
Mm.
That is why in things like football, like even after returning back from injuries, you're gonna start from low quantity of exercises building up, so that the body changes can be enough to accommodate that. But if we just put too much force, because the body is not used to it, that is where that tissue is gonna fail and is gonna rupture. So it's not only in the Achilles tendon; it's more common also in the biceps, where people just out of the blue, they feel like I can lift 200 kgs. Most of the time it usually snaps also, because you didn't give it enough time to get used to those kind of weights.
So Dr. Mugwena, so sometimes you are tempted to lift 200 kilograms with your biceps.
No, I mean, like that normal weightlifting, so some of us, we just go to gym once in 3 months, and then when I get to gym, I'm gonna pick up 200 kg and feel like I can lift it 5 times. So those are the ones who, like, usually they're gonna fail,
Okay.
like
Yeah, then you
something
get
like
these
that. Yes,
failures. No, no, I understand entirely, Dr. Mugwena.
not me.
I was just thinking, I've never attempted to curl 200 kilograms like that. So I just wanted to say, please call me when you do that the next time you go
No,
to the gym. So I understand what you mean is that we need to be doing it more consistently and conditioning our
yeah.
body to take the necessary stress and anxiety there. But anyways, I think there are people that are on the line that are able to join us with the 200 kilogram benching. Dr. Mugwena, then you talked about and what about males when it comes to sports? Especially as one gets older, we try to do different things because we are trying to stay off our feet. Should we do sports? You talked about walking that are more impact related, or are we doing these elliptical trainers where there's no impact on the bones because we were told that the more you walk, the stronger your bones become? Or do you recommend that a different approach? How is it that we can help condition ourselves without actually necessarily focusing on it per se?
Mm, I think also it will also depend on what the person is like is the main aim for exercising, if I can put it like that. Because I think for more of health issues, I don't have much knowledge around it. I think it's more for the physios. But I feel like if I'm just jogging 5 kilometers a day, 3 times a week, I think it will still be enough. But if one day I just try to increase it out of the blue, I think that's the one which it won't be best, for our body. But that I think is more for the physiotherapists who can assist with that one.
Yeah, we do have physiotherapists here on the call. So if any of you want to venture and put your hand up or make a comment, please feel free to do exactly that. And then in with the children, I mean, you showed some younger audience members. In terms of the children, what is it for parents? What kind of advice would you give parents so that they ensure that the children who are driven, especially from a sporting code point of view, are there sports that you have to be more cautious about, or are there treatment modalities, rest? How do you assist your children to avoid these kind of injuries, and then of
Oh,
which can affect the rest of their careers or whatever it is that they wanted to do going forward?
okay. So, in the sports, what I came across when I was researching is that ballet.
Mhm.
Yes, ballet is one of the most common in children, which predispose them to this condition, because most of the time they're gonna spend um, most of the time tiptoeing
Okay.
because of those shoes and everything. So they tend to develop contracture in the Achilles tendon, and
Okay.
then after stopping, and then now they start to put on a normal shoes. The the tension in that tendon, it increases, and most of the time it ruptures also. Yeah, that's what I came across, but unfortunately I forgot to include it.
Okay, so Aaron Shiners, you heard that too much ballet tiptoeing can cause injuries to those tendons. So what is the like the counter? What should they do to counterbalance that? Because I'm sure we're not going to stop any of the young ladies or even gents that want to do ballet and are doing it. What is it that we can do to avoid those exercises? Is it like a counter measure or anything that will avoid the injuries?
Uh, I think more eccentric exercises which can result in training of the Achilles tendon.
Okay.
Um, and unfortunately, I forgot to put the pictures of some of them here.
Okay.
But yeah, yeah. But there are some which were described also, which they do assist.
Okay, yeah, so then it's important, especially again, sporting code. At some stage, there was a famous basketball player. He's passed away now, Kobe Bryant, and then he ruptured his Achilles tendon on the baseball court, and so he returned. I mean, that's a high level of sporting code. So you showed the repair, and you showed whether you're using clips or you're doing your sutures. What's the likelihood of healing for an individual like that to return and continue their sporting passion and code that they are interested in? Do you see the
So
injury happening like repeating?
yes, so Achilles tendon, yes, it does recover, and you can go back to sporting activities, but unfortunately, it takes too much time. So most of the patients or sport people that sustain the Achilles tendon injury,
Mm.
they end up being off sports for up to 9 to 12 months, and also even after returning back to sports, they still have a 50% chance of rupturing, which means out of 100 that we had treated perfectly, 50 of
Wow.
them most likely is still going to fail.
Okay.
So this is because during jumping, so this Achilles tendon, it takes around 3 to 500% a body weight of the person, so which is too much, is it?
Yeah.
So yeah, that is why it usually fails even in well treated patients.
Please repeat that. What were you saying the weight, the impact is and what it
So
carries?
what happened is that during jumping,
Oh,
uh
jumping. Yes.
yeah, so the amount of force that Achilles tendon goes through, it's around 300 to 500% of the body weight of the patient.
Okay.
You see, so that is why even after treating it more, but that load is just already too much for anyone. So it still has chance of fracturing, even if it was treated perfectly.
I think you're definitely not discouraging our colleagues, right, from uh,
No, 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 no.
being active and running and jumping and keeping fit and strong and healthy and maybe watching the weight so that there's not so much impact on this part of the body. So you are, but I'm saying, so you're encouraging that we remain active, uh,
Yes,
and then we can just manage the pains and the aches that come along with it.
yes.
When do you then just towards the end now? Do you when do would you prefer that someone refers patients to an orthopedic surgeon or any of your colleagues that would be more aggressive in terms of intervention so that they don't arrive too late with severe injuries, ruptures? Because sometimes we will see it either from a general practitioner point of view or we see a patient coming for physio or OT or the podiatrist. When would you recommend that that referral happens for towards your discipline?
So the earlier the better. So especially in patients where you can see this calcaneal spare, these are the patients who most likely non-operative treatment, it may not, okay, it's gonna fail. So these are the patients because most of these patients, when they present, it's usually around 3 to 6 months with those symptoms. So those patients preferably send them to an orthopedic surgeon in the next available OPD date.
Okay.
So, but if you want to try corticosteroids, yes, you can give one corticosteroid and see if it improves. But it's important also to document that by the time you refer to an orthopedic surgeon so that it doesn't give another corticosteroid and predispose the patient to rupture. But if it's mid substance
Mm.
uh, lesion, those patients they usually respond well to non-operative treatment. So if they failed a non-operative treatment for up to 6 months, then that is where you can refer them to an orthopedic surgeon. But also keep in mind that yes, you're gonna include a physio also, and and also you're gonna give a corticosteroid, which when you refer, also it will be best to document it so that orthopedic surgeon do not give it again.
That's really important information because, for instance, when patients come in with you on your slide at the moment, you've got the calcaneal, the posterior spur, and then also you tend to get them, at the bottom. And so patients understand would come in for those injections. And I can understand what you mean by it's like a false sense of security because they don't feel pain, but it's actually weakened with all these injections. And then that actually predisposes the patient to not being cautious, and then they end up with a more severe injury going forward. Sure. Is there anything else, Dr. Mugwena, that you want to share with us as a closing remark or parting shot?
Hmm. I know. I think we managed to cover almost everything.
Okay. Dr. Mugwena, I know that it's this time of the year where people are being active, especially, they're starting to be inspired by what they are seeing on TV last night at 3 o'clock in the morning. And so people are more and more trying to be active out there. And so we are going to encourage those of you that want to be active, please, as Dr. Mugwena advocated, don't do it once in a while. Keep active, keep supple, keep moving at least 10,000 steps a day, and make it intentional so that we can all stay young and beautiful out there. And ladies with the high heels on, and those of you guys that are inclined that way, please make sure that you keep your socks on and try to minimize the impact and focus on the eccentric exercises, especially for children going there. And then just in closing, we have a comment from Mandy Nkuna who says podiatrists can manage a partial rupture conservatively by addressing the foot biomechanics and providing heel lifts to prevent further ruptures. They also intervene in complete rupture after surgical interventions during reconditioning and training. Thank you so very much, Ms. Nkuna, for that. And then with those words, I just want to thank the Clinix Health Group once more for sponsoring this evening's webinar and for ensuring that we are able to see the presenters come forward. And we also thank the people in the background who are there now, as well as Tolakele, Sister Masisa. Thank you for assisting and ensuring that everything goes smoothly. I know it's quite technical sometimes. One day we'll give everybody a preview of what actually happens in the background for us to be able to put these presentations out there effectively. And for the doctors and the nurses and the specialists and all our colleagues that are putting their hands up for these presentations, I just want to say thank you. I remember last year, sometimes we were tight, but now we've got this long list and a backlog. I must say, so many speakers that are lined up who want to present and are doing a remarkable, remarkable job. I know you will all confer and you'll concur with me that the quality of the presentations is quite exceptional. And so thank you so very much for that. Next week, we will be talking about bariatric surgery. And so Dr. Mate, who specializes in this field, will no doubt be sharing some knowledgeable information around that. And so we do ask that you please present. And one more thing, I just wanted to say, we normally measure the participation based on the participants that we see on the screen. And then what we found is that there's more than one person sitting in a room behind the computer and are actually participating. And one of the groups, there's Dr. GM Piche. We see some staff there. They gathered today and sitting around the computer screen. And we just wanted to say thank you to them for also being there. And for those of you that are always faithful and loyal and supporting what we are trying to achieve here and do as an organization. Thank you so very much to you too. Please have a good night. Dr. Mugwena, you're sitting in the car, it's cold. Please go back into theater, warm up, and thank you so very much once more for all your commitment to everybody. Colleagues, please join me in saying good night, and thank you to Dr. Mugwena, and thank you very much to you all for joining us this evening. Thanks, everyone.